have the privilege of introducing Dr. John Gravelle. So he is a fourth-year resident in the University of Wisconsin OBGYN program. He was born and raised along with his three sisters in northern Wisconsin by two educators. He graduated from UW-Madison in 2008 with a degree in music performance. John took a gap decade between completion of his undergraduate study in music performance and the start of medical school. In this time, he worked for Epic, a Fortune 500 company, an academic medical center, a global consulting group, and a nationally renowned children's hospital. While working full-time, he completed a self-designed post-bac program to fulfill his medical school prereqs. He then entered medical school at the University of North Carolina, Chapel Hill. I enjoyed going back and reading John's application for residency. And I wanted to highlight, do you all hear an echo? Is it just, no one hears an echo? Okay. And I'm just going to read a few of my favorite parts from some of his recommendation letters. John also possesses a maturity in his interpersonal interactions that is rare to see in medical students at this point in training. He shows unparalleled respect and empathy to patients. He is also a great team player and went above and beyond to help our new interns acclimate to the service. And I thought that exact statement could be said right now. Interestingly, this is still part of a different letter. When first prompted, he will tell you his favorite extracurricular is being a parent of two children. When prompted again, he will tell you his next favorite experience was performing music during memorial services for families who have donated loved ones' bodies for UNC anatomy courses. Always humble, he will forget to mention that he has remarkably continued his work in project management as a senior analyst remotely while juggling the role of medical student and active family member and being AOA. His application overall was superb, and we were thrilled when he returned to Madison for residency. John has continued to excel here, and after residency, he will be joining his family in the best part of Wisconsin, second to Madison, my hometown, in Appleton, Inina, where he will be joining the women's health specialists. Please join me in welcoming John.
Thank you, Dr. Gravelle. I'm sufficiently embarrassed now. Good morning, everybody. The title of my grand rounds is We Built This Mistrust, Addressing the Legacy of Medical Harm in OBGYN. I greatly appreciate you all being here this morning. I have no financial disclosures to report. The specialties in this department represent an extraordinary breadth of care. We care for patients from fetus to elderly. We meet them on their best days and walk with them through their worst. Whether managing high-risk pregnancies as MFMs, treating devastating cancers as gynecologic oncologists, addressing life-altering incontinence as urogynecologists, assisting individuals through their infertility journey as REIs, or guiding patients through their first-time pregnancies, abortions, and severe abnormal bleeding as generalists, our collective scope is breathtaking. The conditions we treat represent some of the most consequential experiences of our patients' lives. Even with this expertise, I'm sure many of us have heard the same question. Are you sure this is necessary? Sometimes followed by refusal, even after detailed explanation. I recently cared for a patient on the labor floor undergoing a trial of labor after a classical cesarean. This was undertaken against the recommendation of multiple physicians. Interactions with her and her partner were tense, emotionally charged, frustrating. Discussions about her clinical course outside of her room were marked with dismay, disbelief, and even anger. How could she so flagrantly flaunt the evidence-based recommendations from multiple physicians, provided in the name of the safety for her and her fetus? I've thought a lot about this case, and many others where patients declined recommendations, sometimes resulting in catastrophe. And I keep coming back to one word: trust. Why don't they trust us? As I sat with that question, I had a thought. Maybe they weren't just mistrusting our recommendations. Maybe they were mistrusting the science, the process, the system. And maybe, just maybe, they had every reason to. Mistrust isn't a patient flaw. It's a reflection of a system that has broken promises, violated autonomy, and justified it all in the name of care. In OBGYN, that legacy is particularly fraught, from forced sterilizations, coerced contraception, and dismissal of pain, to today's attack on transgender and reproductive care. Today, we'll explore how that mistrust was built through historical harm, systemic bias, and ongoing failures, and how we can begin the work of dismantling it. We'll start by looking at the historical events that have shaped the mistrust in OBGYN, especially for Black, Indigenous, and LGBTQIA+ patients. We'll then explore how the mistrust is sustained today with systemic bias and inequities in both reproductive and gender-affirming care. We'll also examine the growing role of social media and misinformation and how they amplify mistrust in ways we feel daily at the bedside. We'll talk about the emotional toll this dynamic has on us as clinicians, how mistrust contributes to burnout, frustration, and moral distress. And finally, we'll end with a focus on action, how we can build trust both in our exam rooms and within the larger systems we're a part of. To understand where we are now, we have to understand where we've come from. Mistrust in OBGYN isn't about one bad interaction or miscommunication. It's a centuries-long pattern of harm, coercion, and neglect. And many of those harms happened under the banner of scientific progress or medical advancement. A typical place to start any discourse about the seeds of mistrust towards the medical establishment is discussion of J. Marion Sims. Sims was born in the early 19th century in South Carolina. He moved to Philadelphia in 1834, enrolled at the Jefferson Medical College, from which he graduated a year later in 1835. In 1837, he moved to Alabama. He set up a permanent practice in 1840 in Montgomery, where he practice primarily consisted of treatment of enslaved persons, which comprised 2/3 of the population of Montgomery at the same time. Some of his earliest recorded treatments in Montgomery included operations on clubbed feet, cleft palates, and crossed eyes. In 1845, a several years period which provided Sims a springboard for the rest of his career and his legacy. Those associated with the consequential period were named Anarcha, Betsy, and Lucy, along with several other unnamed subjects. They were girls, they were Black, they were slaves. In Sims's memoir, he describes Anarcha as a fine, healthy, strapping girl of 17 who underwent an arduous labor and delivery and presented to him with a vesicovaginal. Can everyone hear me?
We can.
Great. Thank you. Obstetrical forceps were developed in the 17th century by the Chamberlain family in England. Over the 18th and 19th century, various designs emerged, most notably Simpson forceps in the mid-1800s. Despite their life-saving potential, forceps use remained risky through the 19th century due to limited understanding of antisepsis, poor anesthesia, and inconsistent training. The cephalotribe was introduced in the early 19th century as an obstetrical instrument designed to crush and extract the fetal skull in cases of obstructed labor. It was used when the fetus was suspected to be dead. However, without fetal monitoring, that was impossible to know for sure. Craniotomy, as a treatment for obstructed labor, involved perforating the fetal skull to reduce the size and facilitate delivery, typically when the fetus was already dead or survival was impossible. The ancient procedure became more systematized in the 18th and 19th century with the development of specialized tools. So this young girl, most likely having already undergone a labor course more horrible than anyone in this room can begin to imagine, now has a large vesicovaginal fistula. Sims begins to operate on an ARCA. After several operations, Sims describes an ARCA as ultimately cured after a final successful operation. He writes in his memoir, "It was not until after many months and many trials that I finally succeeded in curing an ARCA. This was the first perfectly successful operation for vesicovaginal fistula ever performed." As a result of this period, Sims produced and published his surgical technique in the Surgical Reports of 1852. His fame and prestige increased on the foundation of these surgical experiments. Amid arising tensions in the antebellum South in the 1850s, Sims relocated to New York, where he started the New York Women's Hospital. His reputation grew internationally. In 1876, he became the president of the American Medical Association. He received honorifics from governments of France, Spain, Belgium, Italy, and Portugal. He died in 1883, venerated for his contribution to medicine, surgery, and the writers of history named him the father of modern gynecology. In October of 1894, on the burning grounds of Bryant Park in New York City, a bronze statue honoring J. Marion Sims was unveiled. The inscription read, "Presented to the city of New York by his professional friends, loving patients, and many admirers throughout the world." The Journal of the American Medical Association ran an editorial in their November 3rd, 1894 issue, covering the statue unveiling ceremony and venerating Sims's life. The time period of Sims's experimentation is mentioned within, without the mention of the methods or the subjects involved. Between 1845 and 1849, Sims conducted numerous surgical experiments on at least 11 enslaved Black women and girls. These surgeries occurred in a makeshift hospital in Sims's backyard. Sims would also conduct these surgeries publicly in front of medical observers. Three named subjects in Sims's memoirs and in the historical scholarship, Anarcha, Lucy, and Betsy, all underwent multiple procedures. Over 30 unanesthetized surgeries were performed on Anarcha alone. As part of the early procedures, Sims inserted a sponge into the bladder to keep it dry, a technique later abandoned due to the excruciating pain and life-threatening infections it caused. Records show that Lucy nearly died from sepsis following the first experimental surgery. All subjects underwent these procedures without anesthesia. Ether, though discovered at this time, was not widely available. That said, even after it became more available, he still did not employ it during these experiments. Additionally, Sims's writing shows he believed Black people did not experience pain the same way white people did, a racist myth prevalent at the time. During this period, Sims would describe multiple advancements in techniques and technology. He described a position in which a patient's anterior vaginal wall could be evaluated. Anatomically called the lateral recumbent position, this became known as the Sims position. He's credited as the developer of the modern-day speculum from these experiments. He also discussed in great detail the surgical suture and surgical technique of repair he developed for these experimental procedures. From this, Sims was elevated to the pinnacle of his profession. For Anarcha, Lucy, and Betsy, and the other slave girls and women he experimented on, we do not know much else other than that enshrined in Sims's own writing. Sims was part of the white male Southern medical elite, which largely insulated him from professional criticism. The medical establishment of the time overwhelmingly endorsed his achievements. The system created and upheld his legacy, which was built on these experimental surgeries performed on enslaved Black girls and women without anesthesia, consent, or autonomy. This system is what we all have inherited as practitioners of OBGYN care. This is one account of the innumerable ways medicine and the medical system have breached the trust of the patients they served. It is worth reviewing a timeline that briefly reviews other egregious breaches. In the early 1800s, white male physicians began to professionalize and medicalize obstetrics, displacing midwives, many of whom were Black, Indigenous, or immigrant women, with claims of scientific superiority. The exclusion of women and communities of color from both care and medical authority further sowed seeds of distrust of the medical system for those that upheld it. In 1860, governors of every state in the US received a letter from the American Medical Association decrying abortion as morally criminal. This letter contained the notion that life began at conception, where previously it was generally agreed that life began when a woman could feel life move inside her, called quickening. Historians posit this anti-abortion movement was conceived as part of the American eugenics movement, using criminalization as a deterrent for white Protestant women seeking abortion. By 1880, all states in the Union had laws that outlawed abortion in some form or manner. In the 20th century, there are many infamous forced sterilization efforts in the United States occurred from the early 1900s through the 1970s under the banner of the eugenics movement, and were often state-sanctioned and medically legitimized. The North Carolina eugenics program was one of the most aggressive programs, sterilizing nearly 7,600 people, many of them poor Black women and girls. Sterilizations were approved by a state eugenics board, and consent was often coerced or entirely absent. In a similar program between 1965 and the late 1970s, the Indian Health Service performed thousands of non-consensual sterilizations on Native American women, often during or after childbirth procedures. Many women were not informed of the procedure's permanence, were coerced into signing consent forms, or were told sterilizations was necessary to continue receiving health care or welfare benefits. While these historical violations may seem distant, their echoes are unmistakably present in today's health systems, which still exhibit many of the same grievous sins. The California sterilization program is a good example of historical injustices continuing to bleed into the modern day. From 1900 to 1979, California sterilized an estimated 20,000 people deemed unfit to reproduce without their consent. The practice ended in 1979 for state hospitals and in 2010 for state prisons, when eugenic laws were finally repealed. However, between 2006 and 2010, nearly 150 women incarcerated in California's prisons were sterilized without proper legal consent. These procedures were carried out by contracted physicians under the California Department of Corrections and Rehabilitation. These procedures were framed as medically necessary or beneficial. Many women felt pressured to consent, not fully informed of the risks or alternatives, and some were told the procedure was a requirement to receive other services. It was also reported doctors and prison staff targeted women they deemed likely to return to prison, and that sterilization would save taxpayer money by preventing future pregnancies. So as we have discussed, the seeds of mistrust run deep, planted in the historical abuses we just explored. Today they show up in new forms, in the barriers our patients face when seeking care that affirms their identity or respects their autonomy. Mistrust is not just history, it's policy, it's practice, it's perception in the present. Let's take a closer look at the systemic barriers that continue to perpetuate this mistrust today. Across the country, legislative actions are increasingly shaping who can access reproductive and gender-affirming care and who cannot. From abortion bans to restrictions on hormone therapy and surgical care for trans youth, these policies don't just limit access, they send a powerful message about whose health is valued. When patients see their identity and choices politicized, their trust in the medical system erodes. For many, mistrust isn't theoretical. It's the logical response to systems that have repeatedly denied them their autonomy, dignity, and care. Let's review a few examples. In January 2025, President Trump signed the Executive Order 14168, titled Defending Women from Gender Ideology Extremism and Restoring Biological Truth to the Federal Government. This order was signed on Inauguration Day. This executive order withdraws federal recognition for transgender individuals, mandates that federal departments recognize gender strictly as male or female based on biological sex assigned at conception, ceases all funding for gender-affirming care and related programs, and prohibits transgender individuals from using single-sex federally funded facilities that align with their gender identity. Emanating from this single executive order, at least 12 federal lawsuits have been filed, with an incalculable amount of disruption to publicly relied upon data. One of the lawsuits was Doctors of America versus the Office of Personnel Management. The plaintiffs are suing the OPM, the CDC, the FDA, and the HHS on behalf of doctors and scientists who rely on data that were removed at the behest of this executive order. The plaintiffs allege that the removal of this data constitutes an arbitrary and capricious act. At the state legislative level, as of 2025, at least 26 states have implemented laws that limit or prohibit gender-affirming medical treatments, especially for minors. There are some key examples. Missouri enacted the Save Adolescents from Experimentation Act in August 2023, banning gender-affirming care for minors. A Missouri judge upheld the constitutionality of this law in November of 2024. In Florida, Senate Bill 254, signed into law in May 2023, bans gender-affirming care for minors and imposes restrictions on adult patients, including requiring in-person consent forms and limiting prescriptions to physicians. The law also allows the state to take temporary custody of children receiving or at risk of receiving gender-affirming care. A South Carolina law enacted in May 2024 bans gender-affirming care for minors, including the use of puberty blockers and hormone therapy. The law also prohibits Medicaid coverage for such care and mandates that school officials notify parents if a child uses a different name or pronouns at school. Finally, in North Dakota, a law implemented in April of 2023 bans gender-affirming care for minors, with violations classified as felonies for surgical procedures and misdemeanors for prescribing hormone or puberty blockers. In 2024, there were more than 300,000 high school-age transgender youth in the United States. Over 230,000 live in states that have passed laws banning access to gender-affirming care, or where such a law was introduced or pending in the 2024 legislative session. This is slightly more than 3/4 of all transgender youth in the country, although several of the bans were introduced in states that are unlikely to enact them. That said, over 100,000 transgender youth, representing more than 1/3 of the transgender youth in the United States, live in states that have enacted bans on access to gender-affirming care. This is despite the several decades of research and development of safe and effective treatments highlighted in the standards of care of transgender and gender diverse people, now on its 8th edition. With this backdrop, it is then unfortunately unsurprising the mistrust transgender individuals have about receiving care. According to some studies, approximately 22% of transgender adults specifically report care avoidance due to anticipated discrimination. These findings are based on large national probability-based surveys of US adults. Other studies corroborate these rates, with estimates ranging from 22 to 34% for transgender adults. Beyond the fear of discrimination, there are also data that healthcare apparatus denying care. In a study from the American Heart Association, approximately 25% of transgender individuals have been denied health care by clinicians, further contributing to care avoidance. These data underscore the significant impact of anticipated or experienced discrimination of healthcare utilization in transgender population. In the realm of policies specifically related to abortion care, I need not recapitulate the monumental and devastating effects of the 2022 Supreme Court decision in Dobbs versus Jackson that dismantled federal protections for abortion. In returning the power to regulate abortion to individual states, the last several years saw a legislative cascade of state laws, many of which severely curtailed or outright banned abortion access. In states like Texas, abortion was already severely restricted, but post-Dobbs it went further. Texas implemented a trigger law banning nearly all abortions with no exceptions for rape or incest, and narrow allowances for maternal health. This is still being legislated, and with a new bill set to be signed by Governor Abbott in the upcoming days or weeks. Florida passed a Heartbeat Protection Act in 2023, a 6-week abortion ban signed into law by Governor DeSantis, with exceptions for rape, incest, and life endangerment. This effectively eliminates access for most people in Florida. And North Carolina's legislature overrode a gubernatorial veto in 2023 to implement a 12-week ban. These laws don't just reduce access, they create legal and ethical uncertainty for clinicians. Patients are left to navigate an already complex medical system, now with added delays, denials, and forced travel out of state. This uncertainty within the legal and healthcare frameworks created an environment where incompetence to provide comprehensive and necessary abortion care becomes the status quo. This engenders further mistrust of government and health systems to provide the care our patients need. Gotta shake it out. These policies and legislation don't just exist in a vacuum. They're shaped by and reflected in the broader narrative we absorb every day. News headlines and viral posts don't just report on healthcare, they shape how it's perceived. For patients already feeling unheard or unsafe, media and social platforms also often crystallize fears through distortion and sensationalism. The algorithms that control our information can further breed this mistrust. I think back to the Trump executive order we discussed a few slides back that spurred 12 federal lawsuits. The amount of person hours dedicated to combating that single executive order is stunning. Beyond the actual work being done to combat it, we then consider the packaging and dissemination of this information regarding the very complex legal and procedural happenings. Just as clinicians are traditionally trusted to explain the complexities of physiology, pathology, surgical and procedural considerations, We traditionally have relied on media and journalism professionals to help us sort through, sift, and make sense of the immense amount of complex information generated every day. More and more, however, the current media landscape is marred by concerns threatening the trust of consumers and our patients. These concerns include the widening polarization and sensationalization of news and media outlets, and the rise of unfettered social media misinformation. While this includes coverage of the policies and laws such as those we just covered, it goes beyond that, back into the realm of the direct patient care we provide. How many of us have seen this headline? A remarkable statistic from a recent study showing patient satisfaction with IUDs is consistently high across multiple studies. In large cohort studies, up to 90% of IUD users report being satisfied or very satisfied with the method at 1 to 2 years. If you don't remember seeing this news story, it's because I just made it up, and it doesn't exist. Instead, we see headlines such as these. The IUD has become a symbol of medical mistrust as portrayed in news and social media. Studies have not quantified patients who choose against an IUD because of fear of pain during placement, but one small study showed 41% of adolescents and young adults patients would not choose an IUD again because of pain placement. As recently as this month, several news outlets have reported on a new ACOG clinical consensus that was electronically published titled Pain Management for In-Office Uterine and Cervical Procedures. This clinical consensus was accompanied by a news release from ACOG on May 15th. The news media picked up on it with reporting by several outlets. The New York Times article shown here states, to decrease pain associated with these procedures, ACOG now recommends either an anesthetic cream, a spray, or an injected local anesthetic known as a paracervical block. If you read that excerpt from the Times reporter and have read the clinical consensus, you might be confused because what the New York Times reports is not what ACOG recommends. Rather, the clinical consensus reads, every patient who has an IUD placed should receive thorough counseling about the potential for pain associated with this procedure and should be provided with options to mitigate potential pain. Much of this media coverage has undoubtedly been spurred by the social media landscape. Many patients started taking videos of their facial reactions during IUD placements and posting it to social media sites such as TikTok. I had 2 clips here that I was going to show. The audio doesn't work, and instead of having a male talk about the pain that women experience during IUD placement, I won't reenact that. But I have watched these videos and multiple others several times during the preparation for this talk. And even while watching them, I feel the defensiveness rise within me. The desire to provide justification of what good comes from these procedures. Many of us extol the virtues of IUDs. We have data supporting patient satisfaction in the 90% range. We have patients that are happy with their IUDs, but it is this response within me that requires a pause and a consideration for these perspectives that exist online. Research out of Duke in 2022 analyzed the top 100 TikTok videos related to IUD experiences. More videos had a negative tone, 37.8%, about IUD device or intrauterine devices than positive, 19.4%. And 27.6% mentioned distrust of healthcare professionals. Of videos conveying patient experiences, all had a negative or ambiguous tone, and 96.8% highlighted pain and other side effects related to IUDs. Videos scored low on information health quality, 1.2 out of 5 on the Discern scale, and averaged 73.8% in understandability and 17.7% in actionability on the patient education material assessment tool. So in short, these TikTok videos often show an overall negative view of the IUD experience, have negative views on healthcare providers, and are not terribly medically accurate. As one of the authors from the study states, this is not to say that this is not a real lived experience because IUDs are quite painful. It is definitely an uphill battle when I feel like the algorithm does not work in favor of positive videos towards this. Another area of intense social media coverage is the medicalization of childbirth. The vast majority of births in the United States occur in the hospital setting, with approximately 98.3% of patients giving birth in the hospital. Out-of-hospital births, including those at home and in freestanding birth centers, account for a small minority. About 1.1% occur at home and 0.5% in freestanding birth centers. An active area of online discussion revolves around home birth. A recent study in 2024 evaluated 257 posts and over 2,000 comments on Reddit and TikTok from 2017 to 2022, evaluating birthing people's perceptions, attitudes, and advice about planned home births. The results of this study revealed 69% of the posts were supportive of home births, while 20% opposed home births, and 11% were neutral. More germane to our discussion here today are the themes evaluated within this study. Some of these themes centered around the ability to control birth, the feelings that there were superior safety of the home birth, and the concern of prior birth trauma during hospital deliveries. One poster wrote, "My nurse literally told me I was being too loud." Posters felt they could effectively advocate for themselves more at home than in the hospital, and believed their midwives at home gave them more time and support to them than an obstetrician in the hospital would. Another poster wrote, "It is true that doctors often bulldoze over women when it comes to their medical concerns." Other posters say the environment at home was safer than it and the hospital. One said, "Babies are safe at home births in all outcomes and also have an entirely different microbiome." Safety also goes beyond the physical act, as patients describe birth trauma as making them feel less safe in the hospital. One poster said, "I had a traumatic first delivery in the hospital, and that was traumatic solely because the ridiculous amount of medicalization and violation that happened to me in the hospital." Additionally, the home was often perceived as a safer place for people of color or people identifying as LGBTQIA+ because of the potential bias they thought they would face in the hospital setting. The themes of these posts and news stories caused me to think about the historical context I introduced in the first portion of this talk. I think about how common instruments like the tenaculum or obstetrical forceps have been fundamentally changed in over a century. They are intimidating. I think about the process of childbirth in this country was usurped by rich white men from poor women of color. That annexation still reverberates. I think of the history of forced sterilization or the reproductive coercion. Those heinous collective crimes are material to the care we provide today. IUDs protect against and treat cancer, prevent unwanted pregnancies, and control heavy bleeding. Forceps and proper training using them prevent cesarean sections. Modern obstetric care has contributed to the reduction in neonatal mortality from 50 deaths per 1,000 live births in the 19th century to 3 deaths per 1,000 live births today. Self-injectomies provide permanent reassurance many patients seek. When we train to provide these remarkable advances in care and technology, we also inherit their often problematic legacies. I think about the countless traumatic patient encounters I've been a part of. They are gutting. Entrapments, 25-week labor and demises, double-digit liter hemorrhages, surgical complications I have caused, patient deaths. These are hard enough to process. We work so hard to take care of our patients in these most difficult situations. So when a patient declines care we recommend, that hits particularly hard. And we as providers need to recognize the long-term effects that patient mistrust has on us. Mistrust can manifest as patient skepticism, refusal of care, or overt mistreatment, all of which are associated with increased odds of burnout. Experiences of mistrust by patients and families are common and independently associated with higher burnout risk, especially among female and minority physicians. A 2022 survey-based study showed approximately 1 in 5 physicians had experienced a patient or a family member refusing to allow them to provide care. White physicians at 17.9% had experienced a patient or his or her family refusing care, but female physicians and male and female physicians from multiple ethnic and racial groups experienced this much more frequently. 27.5% of female physician respondents had a patient or his or her family refuse care, and more than 40% of non-Hispanic Black males and non-Hispanic Indigenous female physicians reported refusal of care. This chart highlights the contribution of the emotional toll and contribution to provider burnout a patient's declination of care may provide. So what now? As clinicians, we can't control the full weight of history or the harm of past policies, but we must be accountable to them. We must address the mistrust head on. We must understand the active work of earning their trust or dismantling the mistrust through the actions on a large and small scale. At the policy level, the answer is simple, though not easy. and that's through voting. Voting for candidates that supports the health equity for all of our patients is the single most important thing each of us in this room can do. On the side of reproductive rights, public views on abortion have remained relatively steady. Currently, polls show 60% of the US population say abortion should be legal in all or most cases. In the wake of the fall of Roe v. Wade, we discussed some of the damaging bills and laws passed. There are also signs of hope, as many states move to protect access to abortion. Minnesota passed legislation guaranteeing the right to an abortion and removed several restrictions, such as the 24-hour waiting period and increased funding for abortion services. Voters in several states have enshrined access to abortion care in their state constitutions, including Michigan, Arizona, Missouri, and Maryland. Continued judicial and legislative fights rage on in many states hostile to abortion care, including here in Wisconsin. The path for equity on the gender-affirming front is far more convoluted. Polls show that while 75% of Americans support non-discrimination protections for LGBTQIA+ individuals in areas such as housing, employment, and public accommodations, support for gender-affirming care is more ambivalent. In one 2024 Gallup poll, while 51% of Americans said that changing one's gender is morally wrong, 60% opposed laws that would ban gender-affirming care for minors. A more recent 2025 poll, however, shows 56% support laws that would ban gender-affirming care for minors. At the state level, a 2023 Missouri-based poll revealed 73% of Missouri voters opposed allowing minors to undergo gender-affirming surgeries, and 63% opposed minors receiving gender-affirming hormone therapy. Similar to abortion access, many states are passing legislation to protect access to gender-affirming care, as well as laws protecting patients from out-of-state legal actions. It is worth repeating that over 100,000 transgender teens live in states that ban gender-affirming therapy, highlighting the need for continued action to expand protections for care that is evidence-based and life-saving. Narrowing into the systems in which we provide care, we have a more direct influence to drive inclusion, which promotes increased levels of trust. One example I'd like to highlight was mentioned during Dr. Wagar's illuminating grand rounds last week. There he is. The use of clinical trial navigators has been shown to increase minority enrollment rates in gynecologic cancer clinical trials. A February 2025 study showed an increase in from 15% to 36.9% enrollment of minority inclusion with the use of a clinical trial navigator. Systematic reviews consistently identify these navigators as one of the most efficacious and frequently utilized interventions to bolster minority participation in cancer clinical trials. Navigators help overcome common barriers such as fear, communication difficulties, and financial issues, which disproportionately affect minority populations. It is imperative the research arms of our institutions continue to prioritize the inclusion of historically underrepresented participants. These are the kind of efforts we can leverage community and community building to bolster the trust of our patients, whether it's clinical care navigators, doula collectives, or other community-based programs. Discussing these macro approaches is important. However, it can also feel inactionable. Thus, the area that is worth focusing on for our last couple of minutes is the space that is infinitely actionable, building trust directly with the patient in front of us. When I think of how to build trust in my patient interactions, my thoughts immediately go to an obvious place. The Journal of Aesthetic and Art Criticism, and the seminal 2020 article, Winning Over the Audience, Trust and Humor in Stand-Up Comedy. A bit of background here. I have the same spiel for every medical student I work with. As we walk into the patient room, I always ask them where they're from, where they went to undergrad, and what they want to be when they grow up. We typically start talking about the patient. I drop a pearl or two about whatever medical condition that brought them into the hospital. Before we entered the room, I say to the medical student, now there are two things I always make sure to do. One, I make sure to know the patient's name when I enter the room. And two, I observe a golden minute. The golden minute is the first minute of the interaction where I confirm the patient's name, ask who their support person is, and the rest of the minute is reserved for everything except the medical reason that brought them in. I want to let them know we are people with a connection before we get to the doctoring and the patienting portion of what we're doing there. After the interaction with the patient, which hopefully was a smashing success, I often tell the student, our job is very similar to that of a stand-up comic. We have our core material, we walk into a room with roles, preconceived notions, and prejudices, and our job is to quickly earn trust. And if I'm getting into trouble with the trust building, I have 5 go-to jokes that I know will kill with 97% of people. So fast forward to selecting my Grand Rounds topic, and it is not an exaggeration to say that I chose this Grand Rounds topic because of this article. After years of comparing my job to that of a stand-up comic and reading this was the topic I really wanted to talk about. This article painstakingly goes through a rigorous definition of humor, invoking philosophy, units by which humor is measured, and how to discuss the ways humor is analyzed for success. It's also a sign that I'm a really fun hang on the weekends. It also goes through a discussion of how trust is conceived and viewed, and how trust and humor intertwine. In this article, trust is described as and understood in terms of places. One place trust simply offers that person A is generally trusting. 2-place trust is interpersonal. Person A trusts person B. 3-place trust is the crux of our conversation this morning. Person A trusts person B in some domain X. In comedy, as in medicine, we typically think about building 3-place trust, where the audience trusts the comedian in the domain of humor, and the patient trusts the clinician in the domain of medicine. This paper suggests 2 domains of trust necessary for success: competence and intent. Competence is the ability to construct and enact the joke or the sequence or the act. Intent is the domain of meaning for the performance and how it is conveyed to the audience and ultimately how it is received. As highly trained clinicians, we easily recognize and track competency. I am well suited to perform a C-section or a hysterectomy or give the nuts and bolts counseling on a medical abortion. For those that have worked with me, you also know I'm well trained to deliver a perfectly structured dad joke. I offer that the domain of intent is more volatile and is the domain where trust is primarily earned or deteriorates. In joke telling, intent can be as simple as, would you like to hear a joke? However, intent is far more complex. A comedian's basic intent in telling a joke is implied by the advertising, selling a ticket to a show, the microphone, or the stage. Digging deeper into intent is how a joke is imbued with the complex interplay of the comedian's upbringing, sensibilities, use of language, or lived experiences. The act is just as much about the jokester as it is about the joke. Given how complex intent really is, then, good comedy is marked by clarity. Clarity is not simply saying what one means, but rather constructing and executing communication in such a way that the comedian's complex interactions are as clear as they can be. All of these characteristics build towards an important consideration when evaluating one's intent: authenticity. The comedian must be authentic, but even more so, must be seen as authentic. The audience has a say in the trusting relationship, thinking back to the 3-place trust I described earlier, and their expectations determine how the comedian has to respond to earn that trust. Part of what makes this so difficult is that there are varying levels of audience openness. Sometimes you have an audience like this. They are so openly and willingly trust the intentions of that interaction. They do not question the authenticity. They literally laugh at every joke. Thank you, Christina, for always laughing at my jokes, even when I don't deserve it. They are wonderful, but they are rare. Trust building typically requires far more work. Reputation allows for some starting point. However, the trust needs to be built within the interaction every single time. The more the audience's trust needs to be earned, the more skill is required of the comedian. Because sometimes you have an audience like this. Which brings me back to medicine. My reputation, credentials, gender expression, background, and numerous other characteristics may provide the requisite amount of data to show some patients trust me. This profession affords many interactions where that trust is given implicitly. But that is not enough for every patient. In fact, as I've laid throughout this entire talk today, those very attributes I display may lead patients to have baseline mistrust of me. Beyond my personal characteristics, there is inherited mistrust from the system I was trained in, the government that purports to represent all of us, or the media that frames the understanding of my world and my patient's world. So, every patient I see, it is my imperative to portray clarity of recommendation in a complex system and exhibit authenticity in my intent to help with the competency my training has afforded me. I'll say that again. It is my imperative to portray clarity of recommendation in a complex system and exhibit authenticity in my intent to help with the competency my training has afforded me. That is how I build trust or dismantle mistrust. So my framework is the same for every patient. I know the patient's name when I walk into the room. I introduce myself. I confirm their name. I ask them how they would like to be addressed. I ask them who their support person is. I spend a minute connecting to them as a person. I get a lot of mileage out of asking people where they're from, where they went to school, and what they do. I then ask them how they are doing. I ask them what they're excited about. I ask them what they're nervous about. It constantly amazes me, even in the rooms I sense the greatest amount of baseline mistrust, how open patients will be with difficult answers if I just ask them questions. I let them do a lot of the talking initially. I listen. I ask clarifying questions. Because by the time I get to the point where I am making assessments, recommendations, and other doctorly things, I have hopefully shown them the competency, intent, authenticity, and clarity to earn their trust in that interaction. Not every interaction is a smashing success. Sometimes I bomb. But more often than not, I leave the room feeling that this practiced approach earned me more trust or dismantled mistrust. And that is the trust building I can do every single time. The patient who I spoke about at the beginning of this talk, who underwent the trial of labor after a classical C-section, ultimately accepted our recommendation of a repeat C-section and had an uncomplicated surgery and delivery. I feel immensely grateful we earned her trust that day. These are my references, and thank you for coming. Dr. Hanks.
Really great talk. That was just so interesting. Thank you so much for sharing. I feel like I picked up a couple clinical pearls too. I really like that idea of the golden minute, like just taking a beat to listen to your patients. I think that's really cool that you're teaching medical students that too. I think also I was a history major and also took not quite a decade off between, but some time off in between. But I think we can learn so much from history. And so I just find it medical history so fascinating to kind of get an idea of, where patients are coming from. I was just wondering I'm listening to a book right now called All in Her Head, and I can't remember who told me to read it, but it's, have you heard of it or did you? Okay, I recommend you just like with all of this. It goes through kind of what, like specifically women's health, and how just we got to where we're at with basically not studying people with uteruses and how we don't really understand them, and it kind of like weaves in like the mistrust and stuff. But just a recommendation to you and anyone else who's interested in that kind of history and how we got here. But otherwise, great talk. Thank you.
Yeah, mostly a comment, John, that was really just fabulous. And as I was reflecting on our field, the House of Medicine and OBGYN that I've been a part of for now almost 40 years, I think you laid out really well why what we do, the body of what we do is so personal, so critical, and so influenced by socio-political experience, and it changes over time. And I think going back to the entire history is really important. And it is true, whether it's the whole House of Medicine or OBGYN, we do bring that experience into the room, and patients bring their lived experience. So I just want to say thanks for going back through it. Even if we've heard it, we just have to own it, and we have to earn trust. We have to constantly earn trust. And I'm just really impressed that you've learned something that many clinicians, don't learn at the start of their career. They learn 5 years, 10 years in. I feel like it took me probably a decade into my career to really understand that piece where we have all this knowledge, we have all this experience, we have all these things that we can offer people, but it's our offering, it's the medical community's offering. And so always it's the patient's ability to decline. And so I tend to not use the word refused care. I like to sort of just take it out because I think words matter. And I think if a patient is declining your recommendation, they're declining your recommendation. And it behooves us as clinicians to help them understand their situation, understand what we can offer. And then we can't get so tied up in their decision-making. And it's really, really hard at the beginning of your career to see people make choices that you wouldn't make and that lead to their own harm. It's very difficult. That's us trying to figure out how we interact in that space. So just thanks for the presentation and for your wisdom early in your career.
Thank you, Dr. Hi.
John, thank you for that excellent presentation. There were many really relevant and good reminders that I'm taking away from the presentation as far as our practice of medicine, that it doesn't really happen in a vacuum. The history is relevant, the social context is relevant. And so my question is, like, what would you recommend as far as training the next generation of, medical students, people coming into OBGYN to make sure that people are armed with this context, like that they understand what we're coming into, so that folks are prepared to, address and engage with mistrust in our patients and in our communities?
This is a great question. I think that medical training should include context of care provision within all levels of training. And I think that when you systematize it, you have a better chance of spurring that group of individuals, whether medical students or residents, junior faculty, senior faculty, that you give a framework for someone to continue that really important work. I find that the best kind of education is one that lays a groundwork but doesn't hit you over the head with memorizing facts and figures, and you spur the curiosity that is natural to all of us. So I would be imbuing that at every single point of the training process.
Okay, we have time for one more comment. Hannah?
Oh, I really enjoyed the talk too. I love the history lesson and art now. Can you share some of your jokes? Or would that be too painful for the record?
Well,
We've all heard them.
you are not a plant. The joke I put up there was, what do you call a fish with no eyes?
Yeah.
That's why I did not become a stand-up.